Hello everyone, this is Anthony Meddock, one of the co-directors for the Practice of Medicine Ultrasound course, and I'm very excited to present to you one of our newest modules. It is a bit more clinically oriented than many of the sessions that we've had thus far, and I think you're really going to like it. This one centers around the world of trauma, and specifically is called the eFAST exam, or the Extended FAST exam. This is a brief overview of what we'll be doing over the next 30 minutes or so. We're going to go over a brief introduction and talk a little bit about why this is relevant clinically. We're going to go over some of the important anatomy so that you can understand how we do this particular exam at the bedside. Then we're going to go into the details of the technique of the exam. The basic or the standard FAST exam, it involves 4 basic views of the abdomen and the chest. And then we're going to talk a bit about some pathology, as well as some of the extended views that will include looking for pneumothorax, which I think you'll find pretty exciting. And then we'll wrap up with a couple of conclusions and closing thoughts. So by way of introduction, in terms of clinical practice, I am an emergency physician, and so is my co-director, Dr. Elaine Yu. And years ago, before either of us were even actually in practice, trauma was amongst the first accepted application of point-of-care ultrasound, or so-called POCUS, in the United States. And that was done primarily in trauma centers and in the emergency department. And so some rather clever providers way back when came up with this exam, and they gave it a very easy to remember name, and that is the FAST exam, Focused Assessment with Sonography for Trauma exam. And since that time, point-of-care ultrasound has expanded tremendously over the ensuing decades beyond just the world of trauma, but this is kind of where it all began. So just generally at this point, as MS2s, you guys are already pretty familiar with the different ways that we can use ultrasound. Over the course of this particular class that you guys have taken, we have looked at the thyroid, we have looked at the gallbladder, we've looked at the kidneys. Today is going to be a nice session because it's going to pull a lot of those techniques and skills you used and put them all together. And you already know a lot of the reasons why ultrasound is such a popular imaging modality for clinicians, particularly in the setting of trauma. It's very important because if you have a very sick and unstable patient, this exam can be done at the bedside. It's very quick, it's non-invasive, and it's very safe. So even in pregnant patients, you can potentially still do this technique and glean some helpful clinical information. Oh, but just like anything else, there are limitations. There are some things for which the FAST exam or abdominal and thoracic ultrasound will not necessarily find the pathology you're looking for. So you have to keep that in mind. Small amounts of fluid may go unnoticed. So if you're seeing the patient very early on and they don't have a catastrophic hemorrhage, you may not see it right away with ultrasound because ultrasound is not as sensitive as CT scan is, for example. We also are not able to visualize the retroperitoneum. So if somebody has a renal injury or any other retroperitoneal pathology, that is not well visualized with ultrasound alone, and you need to use a different modality. Lastly, solid organ injury is not something that can be reliably found with ultrasound. And then the first bullet point on this slide is personally something that kind of irritates me, to be totally honest, because oftentimes people that are not familiar with the technique will talk about the downside of ultrasound being, quote, operator dependent. In other words, if you are novice, you're not as good than if you are experienced. And while that's certainly true, I think most things in life, including being a good medical student or being a good clinician, are operator dependent. So for me, that one isn't really a big factor, but the other 3 points are indeed important. The FAST exam has many applications, but primarily it revolves around the world of trauma. And in fact, this particular technique for decades has been widely embraced by clinicians from all different specialties and has been incorporated for many, many years into the advanced trauma life support teaching by the American College of Surgeons, as well as widely accepted and used by emergency physicians, anesthesiologists, and on and on and on. So let's talk a little bit about the anatomy. If we think of the peritoneum and we think of basically its shape, when a patient is lying flat on their back on a gurney and they are supine in that position, there's particular pockets or dependent pouches of fluid, or particular dependent areas where fluid will accumulate. One of those is the so-called hepatorenal space, which is sometimes referred to as Morrison's pouch. Another place where fluid will accumulate in the peritoneum when one is laying flat on their back in a supine position is around the spleen and the kidney. And then lastly, in the pelvis, in the rectovesical or rectouterine pouches are also places where fluid can accumulate. It's important to keep in mind that the site of fluid accumulation depends on the position that the patient is lying, whether they're on their side, supine or prone, for example, whether their feet are elevated or their head is elevated, and also the source of bleeding. So depending on the patient's body position and depending on the site of injury, that's going to determine where you're most likely to see the fluid. So let's take a look. This is a cross-section of just a Netter diagram looking at intra-abdominal as well as intraperitoneal and retroperitoneal anatomy. And basically, this is a cross-section through the midsection. We are looking down from the patient's head to their toes. So this is the patient's right side and the liver. This is the patient's left side and the spleen, the stomach, the vertebral body, and the right and left kidneys. And if you imagine the patient, again, is lying on their back. So this is kind of their belly button, and this is their back side. If they're laying on their back, and for example, the patient has been stabbed, or the patient was in a motor vehicle accident and sustained a crush injury to the liver, and there's blood, that blood is going to trickle down and eventually end up in a couple of different places. One is in that splenorenal space right here, and the other place where that fluid might accumulate is right here between the liver and the kidney. So those are two particular dependent places where we're going to look with ultrasound, in the so-called hepatorenal and splenorenal spaces. Similarly, if we look at a pelvis of an individual that has a uterus and we slice them in a sagittal plane right down the middle, this is anterior abdominal wall, this is posterior, okay? You can see the urinary bladder, this is the uterus, and again, if the patient is lying flat on their back, anterior and posterior, and there is an injury to the spleen or the bowel or the liver or really anything, when the patient is lying in this position, the most dependent space is going to be right here. And so that is also one of the spaces that we pay attention to with ultrasound. In this case, this would be the rectouterine pouch. In an individual that does not have a uterus, this would be the rectovesicular pouch. So this is another dependent area where fluid can accumulate, and that's one of the places we want to focus our attention with ultrasound. Now, at this point, you guys are seasoned veterans, and you know that there are different types of ultrasound probes or transducers depending on the type of exam you are doing. In this particular case, since we're looking in deep within the abdomen and also in the chest, we're going to want a low-frequency transducer. In general, the machines that we have in our simulation center are going to be equipped with both a low-frequency curvilinear as well as a low-frequency phased array transducer, and either of those would be perfectly acceptable for this exam. As we talked about earlier, body position and how the patient is positioned on the table is very important in terms of increasing sensitivity of the exam. So this is an example of what's called Trendelenburg position, which simply means head down, feet up. And of course, reverse Trendelenburg would be the opposite, feet down and head up. And depending on where you're looking for fluid, by changing body position, that can dramatically increase your sensitivity. And we'll demonstrate this when we are in the lab at the Sim Center practicing these techniques. So the FAST exam, again, it has that clever name. It's supposed to be fast, and it's supposed to allow you to quickly determine if a patient has free fluid in the peritoneum or the pericardial space. Again, it's got that cheeky name because you should be able to do it in just 2 to 3 minutes once you've had proper experience. And generally, it's done at the bedside in the emergency department or in the trauma bay. But to be totally honest, in some EMS systems, for example, this can be done in the field. This can be done in a helicopter. This can be done on the beach. This can be done in a war zone. It really can be taken anywhere because these ultrasound systems are getting smaller and smaller. So the basic, or the first generation, shall we say, of the FAST exam involved 4 views. That's the perihepatic, and I'll sometimes refer to this as the right upper quadrant view. Some people will refer to this as the Morrison's pouch view. The perisplenic is the second view we're going to obtain. Then we're going to look into the pelvis. That's the third view. And then lastly, these 2 probes represent 2 different windows of looking at the heart, the pericardial space. So that's basically 1, 2, 3, and then this is the 4th view. Steps 5 and 6 are going to be looking in the anterior chest on the right and on the left, assessing for pneumothorax. And that is what defines the basic or the standard FAST exam from the extended FAST exam. The extended exam involves looking for pneumothorax, and we're going to cover all of those today. So step 1, we're going to look at Morrison's pouch, better referred to by its anatomical descriptive name, which would be hepatorenal recess. So to do that, you're going to place your transducer of choice in the mid-axillary line with the probe orientation marker pointing towards the head. Now, this is a cartoon demonstrating the anatomy, but first I want to go over some of the orientation. Remember that in this image here, where we are physically touching the patient, where the probe is touching the patient, that's going to be the top of the screen. So this is actually where we're touching the patient. So this is lateral, not anterior, as is often the case when we're imaging in a different plane. So here, this is anterior, this is lateral, and the sound energy is traversing the liver and going towards the midline. So this is lateral. This is medial. By convention, the probe dot is going to be pointed towards the patient's head, and so that means this is towards the patient's head, and this side is towards the patient's feet. And as you can see, we have liver, we have kidney. That little asterisk represents the hepatorenal space. Also, we have diaphragm. And then above the diaphragm, of course, is the pleural space or the lung. So what's that look like on an ultrasound image? This is the exact same slice, but on ultrasound. So this is lateral. This is medial. This is towards the patient's head, and this is towards the patient's feet. This is how the liver looks on ultrasound. This is the right kidney. And as you can see, there is a nice interface between the liver and the kidney. There is no space between it aside from the potential space and a little bit of that white gray material, which is simply just the perinephric fat and fascia that we all have within our hepatorenal space. If there were fluid in this area, remember, fluid looks black, and you would see an anechoic stripe in this space, which we don't see here. That's good. Contrast that with this image. This is the exact same image, taken the exact same way, different patient. So this is lateral, this is the midline, this is towards the head, this is towards the feet. Here is the kidney, here is the liver, and between the two, instead of the potential space and just seeing that gray-white material of fluffy fat, of the fluffy kind of fatty perinephric tissue, here you can see this anechoic signal, and that indicates free fluid, which in the right clinical context, i.e., patient was in a motor vehicle crash and now has abdominal pain and is hypotensive, then you know this is blood. And therefore, you can take appropriate measures, get the trauma team activated, etc., etc. So that's an example of hepatorenal fluid. Now, we're going to go to view number 2, which is the perisplenic, or you can also refer to it as kind of a left upper quadrant view. You're going to place the probe essentially in the same position, the same orientation with the probe dot towards the patient's head. The big difference here is that, as I showed you a couple of slides ago, the spleen, again, in the normal condition, is going to be much, much smaller than the liver, and therefore you have to make sure you're shining your sound energy through a smaller thing, and that thing is the spleen. As a result, it's easier if you actually position the probe in the posterior axillary line back here, as opposed to in the mid-axillary line, which is where you do it on the right upper quadrant side. So here we often tell learners that you want to essentially have your fingers or knuckles essentially resting on the mattress when you're looking at the perisplenic view. Here's the cartoon. So again, this is lateral. This is the midline defined by the spinous processes that you can see. This is the orientation towards the head. This is towards the feet. Here's the spleen. Here's the kidney. Here is that splenorenal space. And then in addition, with this particular view, it's quite important to look between the spleen and the diaphragm, where this little asterisk is here, because that is a common place where fluid will hide, so to speak, when you're looking at the left upper quadrant view. So what does that look like on the ultrasound system? It's going to look just like this. So again, lateral, medial, towards the head, towards the feet. This is the spleen. This is the left kidney. And as you can see, there's this nice, beautiful potential space between the two that is exactly that. It's a potential space. So the kidney and the spleen abut one another. And all that's between them is a little bit of fascia and perinephric fat. Totally normal. This is the diaphragm. And then above the diaphragm, you have normal aerated lung. Now, contrast that with this image here. Here, what we're looking at is the exact same image, taken the same way. This is lateral. This is medial. This is the diaphragm. And north of the diaphragm, this is towards the feet. And again, here you can see the spleen. Here you can see the diaphragm. But in that subphrenic space, in that space below the diaphragm, instead of seeing the spleen abutting the diaphragm, which would be the normal situation, here you can see that is filled with fluid, and that is free fluid in that subphrenic space between the diaphragm and the spleen. Okay, so now we'll go to view number 3, which is going to be looking in the pelvis. You're going to take your probe and orient it with the probe marker dot towards the patient's right. And once you've obtained those images and saved some images, then you're going to rotate 90 degrees and put the probe dot towards the head. And the whole point of that is that essentially you're going to be slicing the pelvis in a transverse plane and then slicing the pelvis in a longitudinal plane. So you can get all the information you need to look for small amounts of fluid. Here's a cartoon. So this is a sagittal plane. So this is towards the head. This is towards the feet. This is anterior. And this is posterior. Okay, so again, this is the subcutaneous tissue in the anterior abdominal wall. This is the prostate. So this is the towards the feet side. This is the towards the head side. You're going to see a large anechoic structure, a black structure, which is the bladder on the real ultrasound image. And then posteriorly is going to be the bowel. And between the two, that is going to be your rectovesical pouch. And that's a potential space where fluid can accumulate. So here's what that looks like on a real live ultrasound image. Again, antero, posterior, towards the head, towards the feet. The big black, or better term would be anechoic structure in the center of the image, is the bladder. And posterior to the bladder, way back here, would be where the bowel is. And between the two, that's where fluid would hide. And as you can see, there is no black stripe of fluid at the pointer here. So this is a normal sagittal view of the pelvis. Now, if we turn 90 degrees and put the marker dot towards the patient's right, now we're slicing the patient transversely. So now you can see the bladder looks kind of more round and symmetric if you split it down the middle, whereas previously it looked more triangular. So this is a transverse slice through the pelvis. And again, what we'd be looking for, this is anterior, this is posterior, this is now patient's right by convention because the probe dot and the screen dot are on the patient's right. This is the patient's left. And what we would look for is any fluid in this dependent area back here behind the bladder. We don't see any. That's perfectly normal. Now contrast that with this sagittal image of the pelvis. Again, this is towards the head, this is towards the feet, this is anterior, this is posterior, and this is the bladder. And just above the bladder, you can see an anechoic signal right here that's not within the bladder. And that is actually free fluid. Again, it's not a ton, but it's enough, and you shouldn't see it there. In the setting of trauma, someone that has evidence of blunt abdominal injury, this is very concerning for an intra-abdominal injury that may require surgery. Okay, great. So now, the fourth and final part of the exam for the basic or standard FAST exam is looking at the pericardial views. And this can be done a couple of different ways. Most commonly, it's done with the subxiphoid view. So to do that particular view, we are going to place the probe in the epigastrium. Probe orientation marker will be towards the patient's right. And then you're going to have a very shallow angle and basically, essentially, push down your probe resting so that your hand is on the anterior abdominal wall. And the idea is you want to shine your sound energy up into the thorax so that you can see the heart, which of course is way up here. Now, we are going to practice this in more detail in one of your future sessions. We'll have an entire module dedicated to transthoracic echocardiography because there are multiple views that we can use to look at the heart. But today we're going to focus on just this one. This is a nice 3D animation demonstrating this particular subxiphoid view. You can see the probe in the epigastrium, and in a moment you're going to see a cutaway of the sound energy bisecting the heart from the apex all the way to the base of the heart. And in doing so, you can see that interface between the heart and the liver. The liver lights up here at the very top of the screen. This is the right atrium and right ventricle. This is the interventricular septum, left atrium, left ventricle. And again, this is simply a cartoon with that same anatomy. So at the very top of the screen, you're going to see a little bit of liver. Abutting that is going to be the most anterior portion of the heart, which is the right ventricle. You can see the right atrium. You'll see the bright white myocardium of the interventricular septum. And then, of course, you will see the corresponding left heart structures. So here's what that looks like in a live ultrasound image. So liver at the very top of the screen. Right ventricle abuts it. Right atrium is here. This is the interventricular septum. And then, of course, your left ventricle. and left atrium. And the whole thing is enveloped by the pericardial sac. But of course, you can see the pericardium is abutting the diaphragm and the liver. And back here, you can see the left ventricle and the pericardium are abutting one another. That's the way it's supposed to look. Contrast that with this image. So here, it's the same image. There's a little bit of liver at the very top of the screen, but now the RV, the right ventricle, is not abutting the liver. There's a big black space right there, and we know that black is fluid. And in fact, posteriorly, this is the left ventricle, here is the pericardium. They don't abut each other at all. This potential space is also filled with fluid. So this is concerning for pericardial fluid, which in the setting of trauma could lead to cardiac tamponade. So now let's talk about the last two steps of the extended FAST exam. So initially the FAST exam was just looking at those 4 views that we talked about earlier. And then it was decided by clinicians that in addition to looking for free fluid in the peritoneum or the pelvis or around the pericardial sac, sometimes people sustain thoracic injuries, and ultrasound is actually quite good at looking for those as well. So the extended FAST exam is the same exam that we already did, but adds 2 additional steps. Scanning the left and right pleural spaces, looking for fluid, which in the setting of trauma would be concerning for hemothorax, and also scanning the anterior lungs to detect pneumothorax or collapsed lung. So in terms of looking in the right and left pleural spaces, you'll see that this photograph and this probe positioning is exactly like what we did to look at the hepatorenal and splenorenal views. And that's exactly correct. It's the same probe orientation. You want to have the probe marker dot towards the patient's head. The difference here is that now, instead of focusing our sound energy below the diaphragm and looking at the interface between the liver and the kidney, for example, I want to probably slide the whole probe, 1 or 2 intercostal spaces, so I can look above the diaphragm and focus there to see if there's any evidence of injury. Now, one thing that's very important when you're focusing attention and trying to look at the lung with ultrasound is that, for those of you that I've worked with in small groups, you've heard me say before that ultrasound has 2 main enemies, bone and air. And so when you're trying to look at the lungs, which are surrounded by ribs, bones, and are 2 giant bags of air, you can imagine doing ultrasound can be challenging. And so what we end up seeing is not so much normally aerated lung on ultrasound, but we see lots of artifacts or lots of fake outs or lots of kind of just a signal that is indicative that the normal lung is aerated, but you actually can't see lung, because normal healthy aerated lung doesn't really show up on ultrasound. It's only if it is contused, if it's full of pus or full of blood, that you'll actually see lung parenchyma. And that's an interesting thing to keep in mind. So let's take a look at this. So this is a normal right upper quadrant or hepatorenal view. So here is the liver. Here is the right kidney. You can see that hepatorenal space. It's a potential space, and the liver and the kidney abut one another. So that's wonderful. This bright white line here that you see going up and down, or I should say side to side on the screen, is actually the diaphragm. And as you can tell, the fact that it's bright white means that it is reflecting the sound energy very effectively. And as a result, it's giving back a higher amplitude sound wave upon its return. As a result of that, it looks bright white on the screen. But of course, the diaphragm is not flat. It's dome-shaped. And so that sound energy, when it bounces back, some of it goes sideways laterally and then returns back. And so the machine thinks that whatever's closer to the ultrasound probe, which is here, a few fractions of a second later, there's a very similar sound wave coming back, but it just takes a little bit longer. And as a result, it tricks the machine into thinking that there is, in this case, liver on this side of the diaphragm and on this side of the diaphragm. Because if you look at it, it looks the same on both sides. And that is a very important thing that in a normal condition that we see, which is called mirroring artifact. And that happens on either side of the diaphragm. It happens around the spleen. It happens around the liver. And it can also happen around the pericardium. But essentially, you should normally see above the diaphragm, you're not going to see healthy lung. You're going to see what looks like liver on both sides of the diaphragm. And if you don't, that's a tip-off that something is wrong. So here is a normal left upper quadrant view. So again, here's the left kidney. Here is the spleen. The bright white line is the diaphragm. And again, on both sides of the diaphragm, it looks as though there's spleen on both sides of the diaphragm, which of course there is not. But that's the mirroring artifact that we look for and we expect in the normal condition. Now, contrast that with this image. Same perspective. This is on the right side. So this is lateral, this is the midline, this is the liver, and just above the liver is a diaphragm, and then above the diaphragm it should look like liver on both sides, but we don't see that at all. What you actually see here is a large collection of pleural fluid, and this is actually a little bit of atelectatic, which is a fancy word for collapsed lung that's floating in all this pleural fluid. In a trauma scenario, this would be a whole lot of blood, and the patient would be very unstable. So this is realistically more like a pleural effusion in the setting of a large pneumonia or perhaps a malignancy. So this lack of mirroring indicates that you have pleural fluid where one shouldn't. Okay, so the sixth of the 6 steps, so the final step of the extended FAST exam, is to look for pneumothorax. And for those of you that aren't up on your pulmonary pathology, pneumothorax, of course, just means collapsed lung. Now, if you look very closely at this chest x-ray image, you can see a very faint line right here, and that is where the pleura has actually collapsed. So the parietal and visceral pleura have separated, and now you have an air bubble basically extending all along here. The gold standard way to make this diagnosis is with a chest x-ray, but you have to understand that just like any test, chest x-rays are not perfect. They are cheap, they are safe, but they're not perfect. And in some instances, you might miss, up to a quarter of your pneumothoraces, particularly if they're not very large, with chest x-ray. And so therefore, enter ultrasound. So to do a ultrasound exam looking for pneumothorax, you want the patient to be positioned supine, laying flat on their back. Transducer, you can use either the phased array probe or the high frequency linear. I prefer the high frequency linear, but you can practice with both when you're down in the sim center and you can see which you prefer. The main thing that you want to remember is that you want to place the transducer in a longitudinal or a parasagittal orientation so that you're intentionally capturing 2 ribs on the ultrasound image. And by doing so, you're going to get a particular pattern that makes it very easy to identify the pleura. Once you find the pleural line, you want to look for what we call pleural sliding, which I'll explain in a moment. And occasionally you can also see a vertical type of reverberation artifact called comet tail artifact. This is much less important. Sliding is really the crux of what we're going to be talking about now. So this is how you would orient the probe. You're going to place the probe in that just off the midline, in kind of the mid-clavicular line. You want the probe orientation marker to be pointed towards the patient's head. In this instance, we're using the high-frequency linear transducer because it gives much better anatomic detail. So this is basically a cartoon. So again, we're placing the probe on the chest wall. So where we're physically coming in contact with the patient, that's going to be the top of the screen. So this is where we're touching the patient. This is the skin and subcutaneous tissue. This is basically some of the intercostal musculature. This is a rib. This is another rib. And the line that connects one rib to the other, that is the pleura. Everything deep to that is all lung tissue. So let's see what that looks like in a still image. So again, this is skin and subcutaneous tissue. This is the chest wall musculature. Here is one rib, and you can see that because there's a bright white from the bony cortex and then a shadow behind it. And then the next rib, inferior to that, is going to be here. Bright white, black, and then the shadow behind it. So you know this is one rib. This is the next rib down. And the white line that connects the two, that's the pleural line. Not this line, not this line, not this line, but the line that connects this rib to this rib, this horizontal line, that's the pleural line. And that's where you want to focus your attention when you're using ultrasound to look for pneumothoraces. Now, one quick thing before I show you a couple of examples is keep in mind when we talk about the quote-unquote pleural line, that pleural line is not just one static structure. That's actually composed of 2 different structures. Remember, going back to your pulmonary anatomy, that you have your parietal pleura on the chest wall side, and you have your visceral pleura on the lung parenchyma side. Now, in the normal condition, this pleural cavity, this space is a potential space, and the parietal and visceral pleura abut one another, and when you're breathing, they slide back and forth. And this sliding, when you're breathing, is what we see on ultrasound, and that I'm going to show you in just a moment. So here we have a linear transducer. This is anterior, this is posterior. This probe dot is towards the patient's head. This is towards the patient's feet. So the first thing you want to do is find the ribs. And so in this case, you can see there's a bit of bright white with a shadow and another bit of bright white with blackness and a shadow. So those are the 2 ribs. And then the white line, the horizontal white line that connects them is the pleura. So that would be this right here. So that is our pleural line. And now what you want to do is just focus your attention on that horizontal white line and just ask yourself, do you see what looks like sliding? What looks like almost, sometimes people describe it as tiny little ants kind of just walking along a log back and forth. And if you can see that dynamics where you can appreciate that horizontal movement back and forth, that is consistent with lung sliding, which means you have normally aerated lung. That's a good thing. Now, let's look at the opposite condition. So again, here we have basically one rib. Here's another rib, shadow, shadow. The line in between is the pleural line. And I want to ask ourselves, is this line sliding back and forth? Does it have horizontal movement? And I would say yes. Here, we have a rib and a shadow, a rib and a shadow, and that horizontal line in between is not moving. There is no sliding sensation, nor is there any appearance of ants on a log. It's very static. That is concerning for pneumothorax. So normal lung, you see one rib, you see another rib, the white line in between, and if you look at it closely, there is horizontal movement back and forth. That's consistent with normally aerated lung. Now, same thing, rib and a shadow, horizontal line in between, that is the pleural line. But as you can see here, there's no ants moving back and forth. There's no sliding. The whole chest is moving because the patient's probably dyspneic and they're using accessory muscles. So there's an up and down movement, but the whole chest is moving. There's no back and forth. There's no sliding. So this is very worrisome for a pneumothorax. Now, one last step to describe before we wrap up. And that is, what if all this talk of sliding doesn't make sense to you, or when you look at it, you don't really see it, you're kind of scratching your head. If you're still unsure about sliding, there is a secondary technique you can use, and that involves using something called M mode. We talked about this with you guys in one of the introductory sessions many months ago, so I don't necessarily expect you to remember it, but nonetheless, all you have to do, and you'll practice this downstairs, is find on your particular system the modes of ultrasound buttons, which here you can see there's a color mode, there's a Doppler mode, and then there's an M mode. So find the M mode button, and when you activate that on your system, you're going to get an image that looks like this. With your trackpad or on your touchscreen, you'll be able to move where you put this vertical white line. And the vertical white line is basically just saying, okay, we're going to take this one piezoelectric crystal in the transducer and the probe you're using, and we are going to plot over time what this one piezoelectric crystal is actually hearing in terms of the return echoes that are coming back. So the vertical axis is depth. So this is 1, 2, 3, 3.8 centimeters. And same, 1, 2, 3, 3.8 centimeters. And about halfway down, you can see this is the pleural line. So about halfway down, this is the pleural line. Now, normally, if you look at this kind of situation, skin, subcutaneous tissue, muscle, and bone, and up to the pleura, is going to be very static. It's going to give you this pattern of just parallel lines, because as you're breathing, inspiring or expiring, the echogenicity of muscle or bone or subcutaneous tissue and fat is not going to change whether you're inspiring or expiring. However, everything deep to this line here, this is all lung parenchyma. And lung parenchyma is made up of millions and millions and millions of alveoli, tiny little air sacs. And if that air sac is inflated because you're inspiring or deflated because you're expiring, that's going to bounce back a different signal to the ultrasound machine. And as a result, below the pleural line, normally aerated lung will have this speckled pattern. And sometimes people refer to this as a sandy beach sign, or here in San Diego, I like to refer to it as a La Jolla Shore sign. You're sitting here on the beach, you've got your favorite book, and you're looking out at the water. It's fantastic. Here's the waves, here's the sand. So we like that. So this is indicative of normal lung on an M mode image. Now, contrast that with this. So here we have the normal condition. This is just like the image we just saw. Here's the pleural line about halfway down. So about halfway down, this is the pleural line. Lung parenchyma is supposed to look speckled just like that. So we're happy. There's the pleural line, and we see a difference. We see the La Jolla Shore sign. We see the waves. We see the sand. All is good. Now here on this image, the pleural line is up here, maybe about a quarter of the way down. So this is the pleural line here, just like so. The top half is what we expect. This is kind of the normal pattern that we'd see for the waves, so to speak. However, below the pleural line, in the lung parenchyma, we don't get this pretty sandy beach sign. We get what sometimes people refer to as a barcode sign, or I like to refer to it here in San Diego as a rip current sign, because here you're not sitting on the beach reading a book, but here you've been pulled out in a rip current, and all you see from top to bottom is this same type of parallel lines pattern. So this is concerning for pneumothorax on M mode. Again, this is not a technique you must use. It's a secondary technique that you would use in the event that the sliding or no sliding question is unclear to you. So closing thoughts, keep in mind that the FAST exam is a great technique and has many applications. You can use it on pregnant patients, you can use it on trauma patients. The extended FAST is basically the FAST exam, but with some added windows looking for thoracic pathology. Patient positioning is very, very important, but it's often overlooked. So remember, you can increase your sensitivity by putting the patient in Trendelenburg or reverse Trendelenburg, and we can even practice that in the simulation center if you wish. At the end of the day, you want this exam to be fast, but you also want to be thorough. So the trick is with practice, trying to walk that line of being quick, but also being good. So thank you very much. Hope you enjoyed that. Here's my contact information. And if you have any questions, feel free to ask your small group instructors or email myself or Dr. Elaine Yu, the co-directors of the course. Thank you.